oncology team. Um, I work really closely with, and anyone can really refer to me if they have patients who they feel like would benefit from further pain management. So today we're going to focus on learning about the different potential causes of cancer pain, what are some of the common pain syndromes, what the analgesic ladder is, and how it applies to treating patients with cancer pain, and how to advocate for yourselves and how to approach your healthcare team when you have concerns about your pain. So the first thing I wanted to say is that the diagnosis of cancer, especially when you're diagnosed with advanced cancer, can cause a lot of stress. Cancer, just having a diagnosis doesn't mean that you'll necessarily have pain. But if you do, pain can be managed with medications and other treatments. When you and your loved ones are in this situation, meaning that you've been diagnosed with cancer or advanced cancer, it's people face a lot of the burden of physical suffering, but also a lot of other stressors, right? You're there's a threat of losing your independence and potentially impending mortality. And you often have to make really difficult treatment decisions that may have life or death implications. And all the while, you have to navigate this really complicated healthcare system. So cancer pain is just one portion, but it can be a very significant part of the overall bigger picture when someone is diagnosed with cancer. And regardless of cancer type, one of the most feared symptoms is pain. So again, having a cancer diagnosis doesn't mean you'll have pain, but even beyond that, if you do have pain, even if you're diagnosed with the same cancer as someone else, your experience of pain or your pain symptoms might be really different. So your pain regimen or the plan for pain management might be very different than somebody else, even if you have the same underlying diagnosis. So this quote is from Margot McCaffrey. She was a nurse, a leader, and a pioneer in pain management. And the quote is, "Pain is whatever the experiencing person says it is, existing whenever and where the person says it does." This basically just summarizes that pain is a subjective experience, and no two individuals' pain perception is the same. So it's important to not downplay your pain and make sure if you feel pain that you are expressing that and letting your care team know. When your pain is under control, you can focus on other things. But without good pain control, it can really overwhelm every aspect of your life, including your mood, relationships with your loved ones, and your family. So, what causes pain in cancer patients? I like to break things down into several of these categories. Don't let concerns about pain stop you from having your tests done. Make sure you talk to your doctor ahead of time on what steps you can take so that you have less anxiety and you have less pain when you have to undergo a test. So, pain from medical tests, these things can all cause pain. Pain from the actual tumor, so compression on muscles, bones, nerves, your spinal cord, your organs. And this is a big one. So pain from treatment, chemotherapy, radiation therapy, surgery, all of these things can cause pain. And having pain doesn't necessarily mean that the cancer is getting worse. Sometimes it's related to these treatments. And then I also often see pain unrelated to cancer pop up when patients are diagnosed with cancer. So, maybe they didn't have a lot of back pain before, or headaches, or knee pain, and that's not where their cancer is, but they're starting to get more of these other pain symptoms. I find that people's mobility are often changed. It changes drastically when they've been diagnosed with cancer. They're oftentimes less mobile, more sedentary. A lot of that has to just do with the cancer treatments that are planned. Sometimes you're sitting in an infusion chair for 3-4 hours of the day, and you're losing weight, you're not as active, you're not as hungry. So all of these things can just lead to aches and pains that might not necessarily be related to the cancer, but can come up during cancer treatments. So these are just some pain vocabulary in medical jargon. There's nociceptive and neuropathic pain. Nociceptive pain is pain caused by injury to body tissues. It could be musculoskeletal, it could be cutaneous, which means it's on the skin, it could be visceral, which we think of more abdominal, or you can have neuropathic pain, which is also known as nerve pain. So it's pain that's caused by a lesion or some sort of dysfunction in your nervous system. And it can either be in your central nervous system or your peripheral nervous system. And then you can also have mixed pain. So pain that has features of both nociceptive and neuropathic categories. So just to give you some examples of nociceptive pain. So if you were to bang your knee, stub your toe, burn your hand on a stove, that's what we call somatic pain, which is a type of nociceptive pain. And then you have visceral pain, which is this vague abdominal discomfort that's deep. You can't really localize it very well, but it's just sort of in your abdomen. That's visceral pain, which is also a type of nociceptive pain. Then you have the neuropathic pain, which is also known as nerve pain, which people often describe this type of pain with adjectives like stabbing, pins and needles, electric shock-like, numb, shooting, burning, tingling. This pain either can be caused by a lesion, like a metastatic lesion or a primary tumor that's compressing directly on a nerve, but more often it's actually related to the cancer treatments that people are getting. So taxanes like paclitaxel, docetaxel, or platinum agents. So these are the chemo agents that are like cisplatin, oxaliplatin, carboplatin, which are often used in our colon cancer or head and neck cancers. And then there's the vinca alkaloids, which is vincristine, vinblastin, which are often used in our hematologic malignancies. So this type of pain responds really poorly to opioid medications. So like the Norco, the oxys, the morphine, it doesn't usually help this type of pain very well. And it responds better to nerve medications or what we call neuropathic agents, which we'll go over in a bit. And if people are having really bad neuropathic pain, it can be really debilitating. They might not be able to feel their fingers, drive very well, write, use their phones very well. If it happens on the bottom of their feet, they may lose stability, just feel really unbalanced when they're walking. So when this happens, the oncologists often have to decrease the dosing, make adjustments to the cancer therapy, which is not ideal. I mean, all of these cancer treatment doses are based on tons of studies, and so when you have to dose adjust, it may work, but it may not work as well. So that's always a risk when you have to make adjustments to the chemotherapy. So ideally, it would be best to not even experience this type of pain, and we can kind of talk about ways to control this pain or maybe prevent it from happening. So different types of pain. Again, this is just a different type of some different vocabulary that can help you describe your pain to your treatment team. Acute pain is when you have pain that comes on quickly, lasts for a short amount of time, and usually there are periods in your day where you don't really have pain. It's intermittent. Then you have chronic pain. It can range from mild to severe and can persist for a long period of time. The definition of chronic pain, it always really varies. There's not a strict definition of 3 months or more, or 6 months or more, or 12 months or more. Chronic pain, I think at the very least, usually we say 3 months or more, but that definition really varies depending who you ask. Breakthrough pain is usually pain that occurs on top of chronic pain. So you have pain all the time, but there are periods where you have breakthrough pain, which is like a flare in your pain. It usually lasts for a short time, but it can happen multiple times a day. So this is the World Health Organization analgesic ladder. It specifically was developed for cancer pain management. So it's not something we tend to use for non-malignant pain. So people who have back pain from a work injury or something like that. We try not to apply this ladder for that and really reserve it just for cancer pain. It was developed back in 1986, so it's been around for a while. And you can see here there's a stepwise progression of how cancer pain should be treated. So you start with a non-opioid with or without adjuvants. If the pain gets worse, then you go on to a weak opioid, and again, with or without adjuvants, and then a strong opioid with a non-opioid, with or without adjuvants. And so when we talk about adjuvants, we're really discussing things like the neuropathic medications that we talked about, gabapentin, Cymbalta or duloxetine, steroids, muscle relaxants. It can also include things like topical, what we call topical adjuvants, so lidocaine patches, over-the-counter salves, diclofenac, which is Voltaren gel, which is something I use often, Salon Pus pain patches. Those are all topical adjuvants, or even CBD, like a CBD roll-on salve that can be an adjuvant. And then the non-opioids, we usually think of over-the-counter Tylenol, Advil, Aleve, and those can be taken with opioids at any time. And oftentimes it can help opioid medications work better. They can often work synergistically to help the pain. Always talk to your healthcare team and make sure that it's okay to take Tylenol and Advil. I know they're over the counter and sometimes people overuse them just because they're like, well, it's over the counter, it must be safe. If you're on a blood thinner, just be very careful that you're not using NSAIDs like Advil and Aleve too regularly. If you have liver issues, if you have liver lesions, if your doctor has told you that your liver function isn't looking too good, make sure you're limiting the amount of Tylenol that you take a day. So going back to the neuropathic pain, nerve medications, these can be used as adjuvants and can be really helpful with people with nerve pain. We have our gabapentinoids, which is the gabapentin and Lyrica. And then we have SNRIs, which is serotonin and norepinephrine reuptake inhibitors. The big one in this class that we use for pain is duloxetine. The brand name is called Cymbalta. And then we have TCAs, which are called tricyclic antidepressants. And these medications were primarily used for mood a long time ago, but now there are better mood medications, and these medications now are actually primarily used for nerve pain. But all of these medications for nerve pain share common neurotransmitters with mood, and so it can really affect mood. It can also cause dizziness and drowsiness. If you're on any mood medications, always make sure you let your healthcare team know because these medications may interact with them. So make sure you share all of the medications they're on so that your healthcare team can decide what medications and what dosage might be most beneficial to help your pain. We were talking about opioids earlier, so there's mild opioids, stronger opioids. There's also short-acting and long-acting opioids. Short-acting are the ones that people are typically prescribed first. Norco, which is hydrocodone with Tylenol. There's oxycodone, Percocet, which is just oxycodone with Tylenol, Dilaudid, and morphine. These are the typical short-acting opioid medications. Oftentimes people are prescribed this as first-line therapy, or if you had surgery, you might be prescribed this for a short course. So long-acting or extended-release opioid medications, this is what is used when people have chronic pain, 7, 8, or 9 out of 10, all the time. And even when you're taking short-acting medications pretty frequently, you're still having long, severe pain. This is when people might think about starting an extended release medication. And these are just some examples of long-acting meds. MS-Contin, which is extended release morphine, OxyContin, which is extended release um, oxycodone. Xtampza is another brand of extended release oxycodone. There's a fentanyl patch, methadone, extended release hydromorphone, which is dilaudid. It's not used as frequently anymore. I think the big thing to remember about these medications is that if you have an extended release medication, you shouldn't cut them and you shouldn't crush them. Um, Fentanyl patches, you shouldn't cut them. If you have a 50 microgram patch and you think you need less of it or you need more of it and you want to use 1.5 patches or a half patch, don't cut it. If the dose is not right, just talk to your healthcare team and they can send over a new prescription because once you cut the patch, the absorption becomes really variable and it can lead to overdose, it can lead to being underdosed. You don't really know how the medication will act. Same with when you cut or crush the extended release morphine and oxys. So don't do that. Don't cut them, don't crush them if you have extended release medications. That's different for the short acting. If you need a smaller dose, you can definitely do that with the short acting. You can cut them in half. And then this last point down here, short-acting medications are typically used as needed. So they're often written for every 4 hours or every 6 hours as needed. That means you don't need to set an alarm on your phone to take it every 6 hours or 4 hours. You kind of wait for the pain to escalate. You don't want it to get too high, but as it's starting to get worse, you might want to take a dose to try to catch it before it gets to unbearable levels. This is different than long-acting medications. The way that the pharmacology works for the long-acting medications is that they really should be taken as scheduled. I like to think of it as like you would a blood pressure medication or for your diabetes. You need to take it every day the way it should be taken so that it can be released slowly and bring your baseline pain down. I'm going to show a graphic here of short-acting versus long-acting and how these opioid medications differ. So the short-acting medication works really well for acute pain. If you have pain for a short amount of time and then it gets better, you take this medication and you can see that the dose, it lasts for a certain amount of time, it reaches, you have pain relief, and then as the medication gets metabolized and leaves your system, the pain relief section also goes away. So for pain that comes and goes, this is a great option. You don't need to be on anything long acting. But you can imagine if you have pain all the time, you're basically chasing your tail. You take a short acting, it gets out of your system, you take another one, it gets out of your system, and you have this space where you have pain relief, then you don't have pain relief, and then you have pain relief because the medication basically it gets metabolized, it leaves your system, and then now you're in pain again, and you basically have to take it every 4 to 6 hours. And the pain is never adequately controlled at all times. That's when you would really think about using a long acting, and because it releases slowly, the time where you have pain relief is much longer than if you were using a short acting. You should never start a long acting as your first line therapy, even if you have pain all the time, because it takes longer to get released, but it also stays in your body longer. So if for whatever reason you're opioid naive, meaning you've never been on an opioid medication and you take this and you have a really bad reaction, then you're in trouble because it takes a long time to leave the system. So you always want to make sure you can actually tolerate short-acting opioids before you start a long-acting. So what are some of the common side effects of opioids? This comes up a lot, and this is something that you should watch out for and tell your doctors if you're experiencing any of these. Common side of opioid medications are nausea, vomiting, constipation is a really big one, itchiness, can make you drowsy and sleepy, can slow your breathing, and can impair your motor skills, thinking, and judgment. I think that patients tend to be most concerned about constipation and nausea, but as physicians, we are most concerned about the respiratory risks. So slowing breathing, if you're mixing it with any other medications that can cause sedation, it can be really risky. And then when you're dehydrated, drowsy, suffering from fatigue from your cancer treatments, these side effects can be further magnified, especially when you're already not feeling your best. So, yeah, you just want to be really careful with these medications. This is sort of the mainstay on how we treat severe pain in cancer patients, but they're not medications to be taken lightly, and you want to be careful with these medications. So I wanted to just spend a couple minutes talking about constipation because this comes up a lot, and it can really impact people's quality of life when it comes to these medications. I would say that most of my patients who are very hesitant to using opioids is because they had a really bad experience with such severe constipation in the past that wasn't managed, that they'd rather be in pain than use a pain medication that can cause them to be that constipated again. So there are different types of constipation medications: bulk forming, lubricating, osmotic, stimulant, and a stool softener. I think the biggest mistake that people make is that if you have constipation on a regular basis that's not related to opioids, a lot of people will use psyllium husk, they'll use Metamucil, they'll use things that are over the counter like that, which may be fine for non-opioid related constipation, but it can actually work against you if your constipation is uh, from these opioids. So oftentimes people will increase their fiber, but what happens with fiber products is that you're actually drawing in liquid from your body to bulk up the stools, but you're not actually sending the stools forward because it's not a motility agent. So when you're already dehydrated from your chemo, you're not drinking as much, you're on, you have a cancer diagnosis, you're fatigued, you're not hydrating as much as you can. Not only is it making your hydration worse, but you're also now bulking up your stool and it's not moving anywhere, because the reason why opioids actually cause constipation is that it slows down your gut. So what you really need is an osmotic or a stimulant. So things like lactulose, Miralax, Senna, Dulcolax, those are the things that work the best. First line, a lot of people will send people home with Docusate, which is Colace. It's a stool softener. It can be used in conjunction with Senna or Miralax, but on its own, it doesn't actually move the stools forward. And so now you are just having soft stool, but you can still be pretty constipated. So you really need some sort of motility agent to help move the bowels, which will help with this specific type of issue. There's also some fancier constipation agents that are specifically act on opioid receptors in the gut to reverse them, like Movantik, Simproic. I don't know if any of you have heard of those, but those medications can help specifically with opioid-induced constipation, but they're very pricey, usually hundreds of dollars, and insurance usually won't pay for them unless you have tried and failed some of these other over-the-counter agents. Okay. So Narcan. If this can be a really scary topic to discuss, but it's important to know. With the opioid epidemic that's been around in this last decade, a lot of pharmacies will often just make sure that you have naloxone at home. Your healthcare provider often should also prescribe Narcan if you're on opioid medications. This is not It's a nasal spray. It's not something you would ever use on yourself, but you should have in the home, and anyone that you live with should know how to use it. You spray it in the nose only if the patient cannot be aroused. So their breathing has slowed down so much, they're not responding when you're touching them and trying to shake them awake, and you think it might be related to their pain medication, you would use this immediately and call 911. It reverses all of the opioid receptors, so it binds very, very tightly to opioid receptors and displaces your pain medication from those receptors. So what ends up happening is people will end up in severe pain that cannot be reversed and will get pretty agitated. But this medication is a rescue medication for when people may have overdosed from pain medication. So again, scary to talk about and think about, but very important to know how to use. And you don't use it unless it's a true emergency. So if you're like a little drowsy, but your pain is controlled, that's not something that I would use in that situation. But if you can't be aroused at all, then and you're really concerned about an overdose, then that's when this would be utilized. So we saw earlier the three-step analgesic ladder with by the World Health Organization. This is what we call a modified ladder with a fourth step. So the reason why that three-step analgesic ladder works so well is that it's been studied in thousands of cancer patients, and for the most part, 90% of patients can actually get their pain controlled that way. However, 10% of people may need something additional, and that's when you have other things like interventional techniques, nerve blocks, intrathecal pumps, spinal cord stimulators, other targeted therapy. And the fourth step doesn't necessarily have to follow the first three. You can really start thinking about that fourth step anytime. And in addition to these pain therapies, all along the step, if there are other interventions that your team might find helpful, like if you have a bone lesion and radiation might be helpful, that can be inserted along any of these steps to help with pain. So speaking of radiation, this is a very common technique that is used to help with bone pain. If there's a solitary lesion or maybe a couple lesions, it can really help target the pain. Nerve blocks, the most common one that I do and the one that's been best studied for cancer pain is a celiac plexus block, typically used for pancreatic cancer patients with really severe abdominal pain. I think something to keep in mind is that not all pain conditions can be treated with a nerve block. I have patients come to me all the time saying, I really don't want to be on opioids. Can you just treat this with an injection? We can only treat pain with injections if it follows a nerve distribution, and if we can isolate that nerve and block it. So there's only a handful of conditions that actually works for. So not all pain conditions can be treated with an intervention. Tumor ablation, this can be done bone tumor ablation or lung ablation. This can be done by interventional pain specialists or more commonly our interventional radiologists. I'm also a big fan of complementary therapies as part of your toolbox to help you heal and feel better. If it doesn't have any detrimental effects, then I am usually all for it. Meditation is a big one. Mindfulness-based stress reduction. Acupuncture, I would say that over 50% of my patients are always asking about acupuncture. There's very few contraindications for acupuncture, so I think as long as your healthcare team is okay with it, it's worth exploring. VR has been increasing, especially in the peri-procedural space, more so in the pediatric space, but it's a good distractor and can help people distract from their pain. Tai Chi, Qigong, those kinds of things can really help with balance and can also help with pain. Basically can help people with their mobility and strength through exercising. So what about THC and CBD? This is a big topic that comes up in my clinic very frequently. Again, I think over 50% of my patients are using some sort of cannabis product. It's still considered a Schedule I substance. I think that when I look at the evidence, it says that 30% of cancer patients uses some sort of CBD THC product. I think it's higher here because in California, it's been legal for a while, both recreationally and medical cannabis. I think that it's a tricky subject, especially if you're on opioids. I would not recommend mixing opioids with THC. If you absolutely have to, I would recommend spreading it out by at least 2 hours. I never recommend smoking THC. It's really harsh and bad for the lungs. Most of my patients that use it are using some sort of topical salve over areas of their pain, or they're using really, really low dose gummies or tinctures of primarily CBD with very, very low doses of THC if they have to use it. Um, Not everyone's experience with cannabis is pleasant, and it can make some patients feel more anxious, panicked, or even more paranoid. And high doses can actually interfere with liver enzymes. So if you're on a blood thinner, if you have liver metastasis, you just have to be careful when using this medical or cannabis or these kinds of substances. So another thing that many of my patients bring up to me is they're on so many medications. So what's safe or not safe to take together? For many of my patients, especially the younger ones, this is often their first foray into like the medical system. Many of them have been pretty healthy. They probably go get their annual physical once a year, but they've had very limited experience going in and out of the health system. And all of a sudden they're taking, 20 plus pills a day. So what's safe or not safe to take together? In general, my rule of thumb is if there's any sedating medications, separate them by at least 1 to 2 hours. So if you're on gabapentin, you're also on an opioid or a muscle relaxant, those kinds of medications you really want to spread out. If you're going to be using cannabis products, make sure you spread that out from any opioid medications by 1 to 2 hours as well. So barriers to effective pain treatment. There's a few barriers that I think of. One is from the patients themselves, another is from the healthcare team, and then there's also institutional barriers. So I'm going to go through each one of these. And there's just things to think about and just know that they're there. And not all of these will apply to every single scenario, but just know that there are barriers and how we can overcome some of these barriers to make sure you get effective pain treatment. So when it comes to patients, sometimes patients might be a little reluctant to mention their pain. Sometimes they feel that if the pain is worsening, maybe that means their cancer is worsening and they're just scared to know what that means. Also, some people might just feel like, I want to be a good patient. I don't want to complain. I don't want to bring up anything. I don't want to be that needy patient that the doctor, is if I complain too much, maybe they won't treat me the way that I should be treated, or they might not give me the attention I wanted, or I just might not be on their good list. So just know that sometimes patients feel that way, and you shouldn't. If you have pain, please make sure you just bring it up to your healthcare team. I think fear of addiction is a big one. The opioid epidemic, the media attention on fentanyl, the associations of methadone with heroin addicts, and morphine only being used for end of life. These are all things that I've heard repeatedly from patients. I think when it comes to pain management, go in with an open mind. Fentanyl has been getting a lot of bad rap in the media, and it is very dangerous when it's cut into illicit pills. But when it's in a patch form, a transdermal patch form that's FDA approved for cancer pain, it is actually pretty safe. And can really be a good option for long-acting pain relief for the extended version if people need a long-acting opioid therapy. Methadone is another one. I think when it's being used for opioid use disorders or substance disorder, it's being used at doses that are hundreds of milligrams high. When it's being used for cancer pain, we start out at a really low dose, and it can be really effective for treating cancer pain. Morphine is another one. I think the biggest reason why it can come up is oftentimes there's been a lot of drug shortages now. Morphine is an older drug. It's not used just for hospice. It's not used just for end of life. But when there are no other options, or there's insurance issues where different medications can't be approved, morphine is often one that they want patients to try first, and so it is a common medication that you might come across. Other patient factors, so fear of side effects, constipation, nausea, drowsiness, those are the ones that I hear of, and we talked about that earlier. Patients might also be afraid to use strong medications too soon. I just, want to encourage people, like, going through cancer treatment, and just having a cancer diagnosis is hard enough. There's no reason to try to hold out and try to be strong. If you can control your pain, with medications that exist, you should do it. Right. There's always, if your pain gets better, you can always work with your healthcare team to get down on these medications, get off of these medications. But if you have severe pain that's interfering with your quality of life, you should definitely take the medications that can help. That being said, these are very strong medications, and you don't want to, like, tolerance and dependence is a real thing. Use the least amount possible to control your pain, but also don't suffer in pain because you're too worried about using these medications. Um, Clinician attitudes. So sometimes your treatment team might want to focus on other parts of your cancer care. There's a lot going on with the cancer. They might want to talk about a clinical trial. They might want to focus on other aspects of the treatment. And so they might not have time, or they might just kind of brush off the pain. So if that happens, make sure that you bring it up. If your pain's not being controlled, make sure that they know. We talked about earlier about side effects. So when it comes to clinicians, I think the biggest risk, the biggest concern they have is the respiratory depression and how it can cause safety issues in patients who are on these medications. This is an unfortunate one, but sometimes people just don't believe patients have that much pain. I think, like we said earlier with that quote, pain is completely subjective. It's made up of all of our lived experiences, including prior experiences of our own trauma or seeing other people go through pain, and prior surgeries. All of those experiences can actually contribute to our experience of pain, our individual experience of pain. So again, pain is subjective, and your pain is whatever you say it is, and doctors should believe that. Confusion between tolerance, dependence, and addiction. These are three different terms that are often kind of thrown out there, and I think sometimes people don't necessarily know what they mean, and so a lot of times doctors are like, well, you probably don't need these medications. So tolerance and dependence are both terms that apply to opioid medications no matter what. Everyone is going to develop tolerance and a certain level of dependence to these medications. Addiction is a psychiatric diagnosis, and that's when you're using these medications for reasons not for pain. And it's really affecting your relationships with your loved ones, and really starting to affect other areas of your life. Tolerance is if nothing else has changed in your pain, but you're finding that you need higher and higher doses. That can happen anywhere between months or even years. Sometimes people are on the same dose of medication for years without changing their dose. But if you find that you need an increased dose, one is your cancer might have changed, or you develop tolerance. And there's different things we can do. If you develop tolerance, we can also switch back and forth between different pain medications. And then dependence is when you developed dependence to a medication, if you were to stop it suddenly and you have withdrawal symptoms, that means your body has become dependent on this medication. And that is just something that happens with these types of medications. And the last thing with clinician attitudes is there's a misconception that opioids shorten life, which it doesn't. Opioids only shorten life if you take too much of it and it causes respiratory depression. But if you're using the amount to control your pain, it doesn't actually shorten life. This one is a big one recently in the last few years, institutional barriers. Sometimes this is considered a low priority, especially for pharmacies. They often don't have these medications in stock. They have to order it. It's a non-urgent issue for them, so patients are often waiting days, weeks for their pharmacy to get the medication. Unfortunately, there's nothing that the doctors can do about that. There's poor reimbursement for the pharmacies, for the institution, for the doctors treating the pain. So it's often not flagged as a priority. And then the need for prior authorization now for all of these medications, even the simplest first line therapy that used to have not need any sort of insurance authorization often now need prior auth. Availability and access kind of goes with low priority, just pharmacies having these medications. Sometimes it's a manufacturer area and manufacturer issue, and these medications are just back ordered. So we've run into a lot of those issues in the past few years. Help your team understand your pain. So keep a pain diary. This is really helpful to share with your team, but what should you write in it? Usually I tell people to just use a pain score. Rate your pain 0 to 10. Tell me where that pain is, how you would describe that pain, what you tried and didn't try. So was your pain a 9 out of 10 in your right shoulder? Did you take an oxycodone and then went down to a 4 out of 10? So those are the things you can write, and it'll help you keep track, and it'd be really helpful for your pain, for your care team to know as well. So I wanted to introduce one last concept. This is what we call total pain. So there are many different types of pain that can keep us from living our lives fully and having us live a really meaningful existence. We spend a lot of time today talking about physical pain, but that's just one area of pain. So the other areas of pain include social pain, spiritual pain, psychological pain. Social pain is the loss of your role and social status, loss of your job, could financial concerns and worries about the future for your family. All of that can fall under social pain. Then there's psychological pain, anxiety, the fear of suffering, depression, living past experiences of illnesses either in yourself or your loved ones. That can all contribute to psychological pain. Spiritual pain, so anger at fate, loss of faith, finding meaning, and fear of the unknown can all go under spiritual pain. And what they all have in common is that this pain, all of these different pains can be really debilitating, especially if for some reason we're not able to deal with them effectively. So, we all think of pain as physical pain and physiologic, but it really can be a combination of these. It could be something else mostly. So I think that there are a lot of resources out there. Treating cancer is a team effort. So if you feel like some of these other areas of pain are really impeding in your quality of life and your ability to live meaningfully, talk to your healthcare team and see what kind of resources are out there, whether it's through CSC, and they have support groups, or through your cancer team. They might also have other resources available to help you through this. So these are, I think, the last couple slides. Work together with your healthcare team to address your pain. So discuss your pain, don't undermine it, and don't let other people undermine your pain. Set a goal, monitor your progress, make sure you keep a pain diary so that you can actually see how things are progressing or not. Remain in close communication with your healthcare team and be flexible about modifications. If your pain doesn't improve or it worsens, don't be afraid to ask for a referral to someone else who can just focus on the pain aspects. So whether that's a pain specialist or a palliative care specialist, it's important to make sure that if you don't feel like your primary oncology team is giving you what you need, make sure that you ask for a specialist. And then remember, comprehensive cancer care is a team effort. The key takeaway is your pain can be managed. Controlling your pain is definitely considered an integral part of cancer treatment. Make sure you talk openly and you share information with your healthcare team. The best way to control your pain is to stop it from starting or to keep it from getting worse. And again, the pain diary, I have some patients that do this. Um, and it's always so helpful for me to review it with them, go over the numbers and share with them like what it is that we can do better. And then this also gives the patients themselves a way to reflect on their pain. I think everyone's 7 out of 10 is very different, but within that same individual, that their pain scale should be relatively constant. And so it's really helpful when people keep a pain diary for themselves to see how they feel that pain has been doing. Take your medications as directed. Again, when we're talking about opioid medications, they're really strong medications. Do not try to change the dose or don't double the dose because sometimes that's a lot to just double it, depending what your baseline dose is. Don't do that without discussing it with your team. And there are many different medications and procedures that can be helpful and can helping you control your pain. And remember, everyone's plan will look slightly different and really should be individualized toward yourself. And that is it. And I see that there are some questions.
That was fabulous, Dr. Sachs. Thank you. It was so in-depth. I just wanted to thank you for that. That was really something. You covered so many people. I know you're going to look at the questions, but I just wanted to say thank you. I've sat in on many of these talks and this was just wonderful. And yeah, I put in your information. They've got your bio, where you practice, and if they need to reach me for anything at all. So questions away. Didn't want to interrupt, but I did want to say
thanks,
thank
Robbie.
you. Yep. Mm-hmm.
Does anybody have any questions? Thanks for joining me today.
I have a couple of questions actually. Robbie, thank you for joining us, and thank you, Dr. Saxon. This is very informative. So we hear many people with cancer mentioning the fear of addiction. So in a support group setting and individual counseling, and then what are the warning signs to watch for, or how can a patient survivors monitor or follow up on this concern?
Yeah. So I think so again, there's like a difference between addiction and dependence. I think that addiction really becomes an issue. Let's say their imaging is showing that the cancer is actually improving. They're having a really hard time coming down on their pain medication. That's that in that case, it could actually be dependence because, when you're coming down, you might get withdrawals. And so people may be really reluctant to come down. So I think in that case, if things are actually moving in the right direction, we really want to try to push people to start getting off their pain medication. If they're really stuck, or if they're asking for more, if they're using medication, even when they're not supposed to, like that, those are some risk factors. I think the ones that I see is if people have a prior history of any sort of substance use, so if they, I often see people that end up with opioid addiction are those who may have had alcohol use disorder in the past. And even if they're 10 or 12 years sober, now they have cancer and they're on these medications. Sometimes the coping mechanisms are, sometimes I see people replacing their prior substance with opioids. And so that becomes a tricky slope. But I always make sure to share with your healthcare team if you've had any sort of substance use, whether it's alcohol, other drugs, even if it's prescription use in the past. But I think the biggest thing is trying to use the least amount of medication possible to treat the pain. So if things are looking better from the cancer perspective, it's really time to come down. And if people are not willing to do that, that's kind of the first red flag. And then I really try to delve into more like what makes you nervous about coming down. We really want to focus on like those issues and see if we can try to delineate why this is a problem.
Thank you so much.
Mhm.
So I just want to say that I had a brain tumor 19 years ago, and I wrote this in the chat. I had to learn a lot of this through my own experiences, and I think everything that you shared was absolutely fantastic and very informative. And I really feel like this should be part of the intake with the new patients I'm saying this to, Kaio and Robbie, because it's so important to learn these things early on, right? And I feel that's the one thing that I was at UCLA for my treatments. And I feel like this is one thing that wasn't for pain and all these different things. And even, there's so many things that you guys can give patients who are newly informed. That's assuming they come to you guys, right? But this was a really big thing for me. And the constipation stuff, I have to tell you, wasn't just from the medications, because my story is a crazy story, but nobody ever told me that that causes nausea. So mine was that constant, like you're sharing. And a lot of people don't even know that because nobody tells them that. So you have this constipation, you take the Zofran, which makes you more constipated, and the cycle gets worse. So it's so important for people to be more informed in
Mhm.
regards to what can happen with all these medications and treatments and so earlier on, so that, these things don't happen to them as bad, less, you know what I'm trying to say. Because
Mhm.
I had to learn it all, like I said, through my own experiences. And if there was more information out there,
Mhm.
and this goes for, obviously, the doctors should be doing it too, but since we know that often doesn't happen. But
Mhm.
I think everything that you had to say was absolutely fantastic and extremely informative.
Thank you.
And times have changed, if we could clone Sandra, Dr. Sachs, we
Uh-huh.
would. We're at 22 cancer care centers up and down the coast, and I was telling her when I first got on the call before we started that she drives a lot because we've spread her. I put it in the chat, the 3 locations where she sees patients, and I do believe this is still a relatively new field.
Mhm.
And when I got here, her job didn't really exist at UCLA Health,
That's
and it was the oncologists who pushed so hard to add this, I think,
Mhm.
recognizing they couldn't do everything. So I do think, first of all, I'm so thankful that you were very open and very honest about it. And I will take that message to our leadership in oncology, because I do know it makes a huge difference, especially in the beginning, when you have the initial diagnosis. So thank you for that feedback. I don't know, Dr. Sachs, if you
I
want
just
anything
want to
to that.
say that
Yes.
without a doubt, I've seen over the past 19 years, I don't go to UCLA.
Right.
I used to have to go once a month, but thankfully I don't have to go much anymore. But over the
Amazing.
years, I did start seeing the changes where they were having flyers for the relaxation classes,
Yep.
the nutrition classes, the pain management, and so forth. But it wasn't originally there, but there's definitely
True.
changes.
True.
Yeah.
Yeah. For the better over
Yeah.
time, and a lot more work to do. So thanks for
Mhm.
that, Michelle. Does anyone have any other questions at this point? We've hit right on the dot. Look at that,
Yeah.
the 1 o'clock mark. We never do that. I put my contact info if anybody needs any other help. And I just, thank you for your time. This was amazing. I learned something new, and I sit in a lot of these talks. So I do appreciate all the time you took to put it together. And I don't know if I want to throw it back over to the cancer support community. Do you have anything else you want to add?
Yeah, Robbie, yes. Javeria does have one announcement about the survey.
Okay. Okay, great. Thanks, Kai.
Dr. Sachs, I just want to thank you. I think you answered a lot of my questions that I had listed, so you kind of nailed everything that I was gonna ask. Thank you
Great.
for giving such a comprehensive
Yeah.
view on, side effects and ways to treat to treat oncology related pain. It was very resourceful, and I think, again, this is a very growing field, and I hope that, we make a lot of more progress in this field and, you know, and thank you so much for touching up on the opioid addiction. That's also something that we may not think about right away. But it's very, very important. So I really do appreciate that.
Yeah, you're welcome. Thank you guys so much for having me and joining me today.
Thank you so much. If nobody has any questions, I just want to close out. I did include our program guide for this month, so any new events that are coming up, you can check that out. And I will be linking the survey, so you can leave your feedback. And that survey really does help out a lot. We just want to know what you would like to see in the future. And I really hope that this presentation was just as helpful for you as it was for me.
Okay, great. Wonderful. All right, thanks for putting that in,
Thank you.
Gingerbread. We're gonna pop off. All right, on to the next
Okay.
thing.
Thank you so much.
Thank you,
Thank you.
everyone.
Thank you. Thank you so
Thank
much.
you.